So welcome back, everybody. Thank you for that wonderful talk this morning. So now we have a panel who is going to reflect on the talk this morning and let us know their thoughts, what resonated with them about the talk, or any comments or questions. But before we do that, let's have them each introduce themselves. Shall we start? I'll start on that side.
It's not going to help. You'll get my name.
Hi, my name is Keith Landherr. I'm an occupational therapist and the director of Little Betty's Pediatric Therapy.
Hi, my name is Chamila. I'm a parent of a 15-year-old son with autism.
I am Anna Maria. I'm a community pediatrician and a community researcher, and I work almost exclusively with children with what I call behavioral complexity.
I'm Lee. I'm an autistic adult. No other relevant professional qualifications.
That's great. Okay, thanks. So let's start off with any thoughts on this morning's presentation. Anybody who would like to start, or?
I can start. I have some thoughts.
Yes.
I liked when she was like, it's kind of a duh, because it's kind of a duh. So that was nice. It's cool that there's actually like research to prove the duh in process. I like that. I thought the impact study, or the impact, whatever it's called, the impact thing, I thought that was neat. I'm curious, like also we were kind of already talking about it, of how it seems to be specific to the group where parents are more highly educated, and I am curious about like beyond just education, like what other factors are influencing that and what other things could we look into, because like we were saying, like not only is it difficult possibly for them to like access the training for how to do that, like how could we make that training more accessible to more people, but also resources outside of that, like time, money, support from other parents and caregivers, that kind of thing. Like it seems almost more like it would be a class issue rather than an education issue in many ways. So I thought that was interesting and would be cool to look into that more. And then when she mentioned, like, could we transfer it to having clinicians providing the impact thing? What's it called? The impact intervention. Thank you, professionals. To have clinicians providing the impact intervention, it would be interesting to see how effective that is, because I feel like part of it, too, with it being the parents, is like the kids already, hopefully, typically will trust their parents, so that's like a person they're comfortable interacting with in that way, whereas if they're meeting a new clinician, they might not feel comfortable, and that might not be a positive learning experience for them. And beyond that, parents are possibly taking some of those strategies that they learned from that training and then just applying it generally in everyday life outside of doing the intervention, just like in their casual conversations with the child. So I wonder how much that could be affecting it as well. And then sorry, I'm talking a lot. I'm almost done. With expanding it to other neurodevelopmental conditions, I'm curious about how it might benefit like all children, because it seems, I don't know all the details on impact, but from the brief overview, it sounds like it's like having meaningful one-on-one communication with a child, and that seems like it could be beneficial for any child's language development. Taking that time to be like one-on-one and face-to-face and really having like a deep interaction with them seems like it would just improve any child's language development and their social engagement. So I'd be interested how it would affect all children, really, and how the difference compares between like a typically developing child and a not typically developing child, if it has a more significant effect on one group versus the other, or if it's really just it helps everyone. Communication, one-on-one with parents, is good. That's all I have to say.
Yes. First, I'd like to thank Michelle for giving me the opportunity to join the panel. And my thing is like this social hypersensitiveness, the hyper-responsiveness is like my son is like he's sometimes sensory seeker, sometimes sensory avoidant. So he's in both. So I can see it's hugely impacting his life, like social communication. And so sometimes it's like we just jump into conclusion, so like whether it's like, is he seeking sensory or is he avoiding, So it's, even for me, sometimes it's hard, and the people that work with him at school, and it's hard to, like sometimes he would do like this, and like, it's like we don't know whether it's like he's seeking or he's like avoiding, So like for me, like interacting with him day to day, so I know sometimes like it's not that he's like avoiding, like sometimes he likes it, but he does it too, and yeah, sometimes he likes it, really likes it, so he's excited. So that's how he's showing that I like it, and sometimes he would do it because he wants to avoid. So sometimes it's confusing, and it's really, really disturbed with his social communication. And I like to see more research on like Gestalt language processing, because my son is a Gestalt language processor, like he's speaking with the scripts. So those kind of areas, so I think it's very, very beneficial, because that is disturbing as well, because I know dealing with him every day, like what he's trying to say, like, but some people like working with him, they don't know, like he's saying something, like some show that he's watching, but I know he's trying to communicate something with it, so I always like model it and expand it for him, but then it is hard when he goes to other places, people would not knowing what he's trying to say, so it's sometimes it's disturbing, I notice, yeah.
Yeah, I think that I'm going to kind of piggyback on what she was saying, that when we're talking about research and sensory research, it's really hard to do, because as a clinician, I don't want to follow the same exact protocol with every child, especially after doing this for 30 years. If I was a new therapist, I might do that because you're trying to figure it out, right? And you can do it in a way that the child is benefiting as well. Because that joint discovery can be really wonderful, and they know that it's a joint discovery, and they trust you because you're sharing it with them. But all of that has to do with co-regulation as well. So if you're not regulated, you can't attend, right? So what sensory stimuli is causing the dysregulation and preventing the attention? And, there are studies that show that if somebody is trying to nurture somebody or provide input that is perceived as being noxious, even though it's not noxious to somebody else, it's still noxious to that person, and then they tend to be more avoidant. I also wanted everyone to know that the sensory profile is based on behavioral observations, and then stats are used to find out where everybody falls within that range, right? And I like the test that she was showing because it's so cause and effect, and I thought I really should have my therapist do this, because sometimes they don't connect the experience in the way that I do. I can like have a child or a family walk in, and I can say, mom's hypersensitive to touch and he's hyposensitive to touch. I at this point I can just see it, and it's a journey to do that. And so when a child is really young, helping them regulate, you're more likely to integrate your senses in the way that they need to help with all of this sort of social function, language development. But just one last point is that, so as a sensory OT, the most important triad for me is actually vision, hearing, and balance. So she, like for language development, she's focusing on hearing and vision, and that other piece says, well, if I can be stable, then I can actually do all of that. If I'm not stable and I'm worried about falling over, I can't. And I can't have a conversation with two people because I can't turn my head. I probably have said too much, but I use the sensory processing measure now because you can actually give one to the parents and it gives you more information. and then you can have the spouse cross-check the information by giving the same one, and then it can be, well, you're complaining about this because your profile's like this, and you're complaining about this because your profile's like that, and help them bridge that level of understanding.
Great. I think I'm going to ask a question, just because I'm the moderator and I can.
Sorry, do you mind if I jump in
Oh,
and
I'm
answer?
sorry. Yeah, go ahead. I thought there wasn't another.
Just because it's a little bit of a different lens or approach. I think the things that stood out for me on the talk this morning, one of the questions I would have liked to have asked Tiffany, I'm not sure if she's still here, is around there's a social hypo-responsiveness and then the sensory that followed. What I was actually wondering was how much like face-to-face time these kids were actually having before they presented to her. Because I do keep wondering as a pediatrician, like the impact of that parental-child kind of like face-to-face interaction. And then that got me to thinking, like, in terms of the education of the parents, I actually started wondering if they did the sensory profile on the parent, because I wonder if you're a parent who's already maybe a little bit internalized and a little bit, approach life a little bit differently, like what impact does it have on your child? And then that got me to thinking about the so what? Like, does it matter if we actually increase social communication? Like, what is the benchmark that we're aiming for in terms of social communication? Is it a neurotypical benchmark? Is there a neurodivergent benchmark that maybe we should be looking at? Like, what does a neurodivergent benchmark look like? And then for me, like, always, I don't like labels and diagnoses, even though I'm a pediatrician, I don't actually care about them. It's about the functional, how is this actually impacting you? How is this preventing you from being happy and joyful and enjoying life and, wringing everything you can out of it? And so those are my thoughts.
That's great, because that's where my question is going. So my conundrum is, although I don't have any research evidence to prove this, but I have lots of clinical experience from little, toddlers to adults. And I think that sensory processing differences might be related to some like really good stuff, like art, artistic talents, musical talents, other sorts of wonderful things. And I understand the need to address sensory processing differences in certain circumstances, but then how do we balance the good stuff that they give us versus the stuff that interferes? Like how do we balance that? And how do we know, right? How do we know that some of these early, like I was struck by some of those toddler videos that Tiffany showed, those reactions early on seem pretty, significant. But, from a developmental perspective, do they continue in that way? Do they, do things diverge at a certain point? Like, how do we know that they necessarily will lead to social problems or difficulties in other areas over the long term? And how do we balance, how we address them early on versus how we take them into account in terms of the whole child? So any comments?
I think you're what we try to do and what I've always tried to do is that you make it tolerable or give the child the tools so that they can let people know how to make the experience tolerable for them. I like when people talk softly, and it doesn't take it becomes a choice of how what sensory channel they want to focus on. And I don't think it will take away from the artistic quality of them, because that's in lots of different centers. But you just want to be able for them to make choices and to live a tolerable life as much as they can. I'm a very sound sensitive person, so that's probably why the sound guy put the mic closer to my face, because I talk very low, because everyone in my family has really good hearing and we all talk really low. And people will say, I can't believe you guys understand each other, but we do. And so then I have to be reminded to speak up. And so it's about making it into something that is more of a choice rather than something that's aversive.
Right. Okay. Any other?
I kind of agree on that of like, I feel like I didn't necessarily have that as a child. I was not aware of my sensory needs as a child so much. Like, I remember being in loud, busy classrooms and being totally overwhelmed, but I didn't know why. Like, I just thought everyone felt like that. I didn't know that was a me thing, and I didn't know there was anything I could do about it. Whereas now that I'm an adult, like, I'm more aware of what I need and then can either arrange or ask for what I need. So that definitely is helpful, in my opinion. And giving children that autonomy and, like, helping them to discover what they need and why they need it and how they can make it more tolerable, I think is important. And yeah, like, I think focusing on, like, the sensory aspects that the child finds to be negative is important. Like, why bother changing something that they actually enjoy? Like, if the child's gonna put his face up against a fan, like, go for it. That's not hurting anybody. He's loving it. Like, what's the problem there? But if that's something that's like, if there's a different sensory experience that's like causing pain or distress, I think those are the more important ones to address.
So Tiffany wrote a comment. Yes to this comment is exactly why I'm torn, whether we should intervene upon sensory differences at all. Yeah, it's an open question. I don't know. So I guess the problem with the fan is that the child is so engrossed in the fan that they're not paying attention to people wanting to interact with them or, social bids. Is that a problem?
Is it a problem for the kid? It's maybe a problem for everyone else in the room, but
yeah,
if the kid's happy, I don't know.
I guess I'm just thinking about that. I think this is a really, really important question. I think something a lot of clinicians are struggling with. And so I guess the concern is the focus, right? And that I think everybody would be very happy for the child to be happy, but if they are not learning because they're so focused, I think that's the concern clinically. And I think it's a real bind. Because I think most clinicians do not want to teach a child to invalidate themselves, right? Like, that's not why people get into the business. And yet there's been a classic conceptualization that the strength of the sensory interest or other things can be so dominant that it prevents learning in other spheres. And I don't know, like, that's the conceptualization. I just want to, like, throw that. I don't know if it's 100% accurate or not, but I think that's what we're dealing with. So, I think that's the struggle, right? Which is how intense it is. If you are missing other information, including language, et cetera, is that the concern? So, and I don't have the answer, but.
Yeah, I think you put your face in the fan with the kid and see how they respond and try to make it into a social interaction. Yeah. Or get a small fan or whatever it is. And also, if you can figure out what kind of sensory input they're looking for and you can give them even more of that same one, you'll help them work through it faster and they'll really appreciate you and they'll start to trust you and pay attention to what you're saying and see a reason to try to attend to you because they'll think that you get them.
Yeah. That's actually kind of what I was about to say. I'm just jumping in here because I was second author on a study that's published now in JAD, I believe, a qualitative study of some autistic people's perspectives after viewing videos of an intervention that's sort of in the same family as Impact, one of these naturalistic interventions with young children. And, the autistic participants in the study were raising concerns if, people were creating opportunities for social interaction in a way that seemed very coercive. Like, for example, if they were sort of like taking, the thing that's blowing the air and like in this example, and if they were like to take that and sort of hoard it unless the person like produced spoken language or something, then people would find that very coercive, and they would find the focus on spoken language to be troubling in as opposed to like a focus on communication in general. That was very clear in the qualitative feedback, but people were not at all opposed to the idea that you could have, as you say, these positive social interactions, around things that are of interest to the child, and trying to socially engage them around those, and experiences that they are enjoying and exploring in their environments. So yeah, for what that's worth.
Yeah, great. So it sounds like there may be other ways of meeting both goals, like sort of going where the child is. So here we have a question from people watching virtually. There's one question to Keith. Do you give the adult sensory profile to parents or teachers to find out if there's a mismatch in their sensory needs?
I've begun doing it with parents, not with teachers, because they tend not to want to complete them even for the child, I find. They'll do them more like if it's very specific to like the cafeteria or something like that. But it's quite helpful, and we're trying to do more of that. But we just started bringing that online.
There's another question here from Susan. That was what I was wondering too when I asked the questions about gifted children, as they often demonstrate similar sensory and or cognitive differences, example, attention, yet are able to use these differences to their advantage, in a sense.
Can I just make a comment? The other thing I think, this is like very interesting, but the other thing I think we were talking about a little bit is, and I just want to maybe back up and say, like, I found the talk this morning incredibly fascinating, and I think that science and like understanding and exploring and all of that is incredibly important. And so like the critiques I had were not critical at all. I found it fascinating. And for me, I do definitely see like many kids that come through the door to see me. The ADOS, ADI, yes, I can do those, and I do autism assessments, no problem. But like when I'm taking a history, like the things that I do end up focusing on, my ears perk up when children have a difficult time sleeping, when they have very picky eating, and when they're not toilet trained, at an age where you think that they might be. And so I think that all of those are actually like in the sensory kind of domains. I think that, like, for me, it's so interesting to hear about, like, sensory focus and OT, which I totally recommend and value completely for my patients. But, like, I also, coming from a medical lens, I always think, like, what purpose does the behavior serve, right? And in my, like, formulation sometimes, I feel like anxiety and sensory seeking or avoiding behaviors are actually quite intertwined. And so I find that there's a lot of benefit to approaching kind of a behavior broadly, and to really try to explore, expand, like why this behavior now, I guess, right? And no, I'm not a PCBA, and I understand that, but what purpose does this behavior serve now? And I think that sensory stuff is actually regulating. And so I can view that again from an anxiety perspective. I think that video games are another like sensory seeking, and again regulating like the dopamine pathways and all of that. So I think it's like all so intertwined, and like trying to focus on one, you end up like losing sight of everything. And so all very complicated.
Yeah, I think I have a very holistic way of looking at the kids, so I agree with you completely. And it also has a very protective mechanism, right? And so when you look at some of the families, some of the families that were lower socioeconomic or less educated, I would posit that many of them were multi-generational sensory differences in their families, and probably in the tail end. And that's part. And when you have that experience, you have anxiety and you have stress, and so you have, in a sense, multi-generational trauma. But we don't look at it that way. But when you look at some of the papers that were done with First Nations groups, I've seen families from every origin. I used to work in New York, and I was mostly in ethnic neighborhoods, and everybody was the same. And if they had a lot of sensory challenges, the parents had a really hard time working, and I could just see it. I didn't test it. So it's interesting because in many ways I have to look at both the parents and the child in order to give the parents something that is going to help the child, that's going to work for the mother, and so that the family function and the happiness within their environment becomes tolerable for all of them. Yeah. And some of it is just even being able for them to say it, like when you're or acknowledging when the child is doing something that the behavior means something else, like, oh, I see you really need a bit of help right now, rather than you're talking too loud, sit down.
I think like with my son, I noticed that the anxiety and the sensory processing go hand in hand, So like sometimes like he's doing these sensory things because he's so anxious. So he like chew his shirt and things like that. And then I agree with Dr. Koda that, because it disturbs his learning. Like sometimes when you give him I noticed with my son, like if you give him a fidget toy, like he would be fidgeting it, like it's actually like it's not like, sometimes it's rather than helping, it's like he's zoning into it. Like he's in like a different zone. So it's so hard to, like, even though he's capable of doing something else, like because of that, he's just like doing it. So I think I agree with Keith, like take it as a learning opportunity, like build the interaction like with that thing, and then expand it to like a learning experience. So I think that is what I noticed with my son. So I always like give him that sensory breaks, but at the same time, I just make it as a learning experience. Like I noticed with him, giving him more skills and teaching him, like take this opportunity and teaching him some skills, actually it helped him. So now he was like, when he was diagnosed when he was 2, so now he's 15. So I could see over the period of time, like we took that thing as a learning, we built the relationship and then we just expanded it. So we taught him lots of leisure skills. So now he's not sensory seeking that much. And he's like using like his hands, he's playing piano now. Before he was doing like this, So we took it and we expanded it, So he's like he was like running around, so like the hype, so those hyperactive. We took it like playing games, like swimming and like playing tennis and things like that. So we just expanded it. So actually, like that thing, we took it, that sensory seeking, we took it as a learning experience and expanded it. So I think it helped a lot.
So you're saying it helped you understand your son better, and because of that, you have a better rapport with him, and were able to extend into other areas. Of
because
learning.
I agree that like when you give him like a sensory thing, like he would zone into it, and then it disturbed his social communication and interacting with other people, because he thinks like, okay, this is what I'm supposed to do now, and then he's like zoning into it. So we took that opportunity, like we just built it for him a learning experience, like little bit, we just expanded it, and then we taught him something. So without he's like having the skills too, like he didn't know what to do, So we'd rather running around, but now teaching him something, so now he knows like, okay, I can take that to like something that I can do with it, So it's like day-to-day life, it's helping him. Yeah.
That's a fantastic example.
Yeah.
So another question would be to the panel: have you had any experiences with sensory processing differences that were, techniques that were really helpful in either alleviating, difficult sensory processing issues, or that you used the sensory processing differences in some positive way, it impacted, just like this example. Any other examples of that? Or
I think kind of touching on that and that, bringing them together. A lot of the time, you can view like sensory behaviors as not necessarily communication, but a type of communication, and you can look at those behaviors and instead of just being like, why are they doing this? Oh my God, they need to stop. Thinking like, actually, why are they doing this? And then kind of like she was saying, finding other ways to like engage that sensory activity that the child is also going to enjoy and maybe even find more benefit from. Like sometimes you might have a super hyperactive child in a classroom and they're disturbing everything, but it's because they need to have a break. They need to go outside and like run around for a few minutes and come back and they'll be fine. So I think looking at the child and their behavior and whatever sensory seeking or avoiding they're doing, and then finding ways to match that and like encourage it in positive ways and accommodate it when they're having a negative experience. Like I think that's beneficial in almost every case. I don't know if there's a case where it wouldn't be beneficial, but yeah.
I think that like if you figure out what the sensory seeking is doing, so if they're just going out and running around, which is great, I'm not saying it's not, and kids should be able to have some free time to just have their sensory fun. But if you add tag to it, it's slightly more organizing and it's more social. And the more you can just put an organizing overlay onto it so that it has a structure. So even if it's like running down there and running back and waiting 30 seconds on the one end and going there, then you've provided structure. There was a kid who wanted to go up the slide all the time, and I went up and I said, this is what you can see up here. And that made that a social interaction. And then we would kind of do obstacle courses in the playground. But I really like your example of your son's doing this. And for me, this is saying that I'm not receiving enough proprioceptive information to my brain. And so I'm seeking it out. And I really want to be able to use my hands. And then you figured out, well, if he does this on the piano, he's using his hands, it's organized, it's structured. And so that's kind of the creative lens that we have to use, because all of us are different sensory-wise, right? And sometimes we wake up in the morning and we're different than we were yesterday. So, we have to be creative.
I think, I'll just make one point. Again, speaking as a physician, I think that one of the big things that I've realized in my years of practice now is that I really have very limited things I can do. I can prescribe and I can refer. It frustrates me that I can't write prescriptions for occupational therapy. I can't write prescriptions for what kids actually need. And so then I'm limited in terms of medications. Sure, I can do that, but it's incredibly frustrating because it sets up a huge inequity, in terms of who can access appropriate intervention. Because I also am a firm believer that there's lots and lots and lots of different therapies and not one's going to work for everybody. And so the idea of finding the right fit for the right person, but all of that goes out the window in the system that we have right now. And it's kind of well, this person's available, so maybe I'll take them, or this person's on a bus route I can have, or this person will come to my house, or, all of these other things are really limiting access to appropriate intervention in the way we currently have our system in British Columbia. So just a comment.
Thank you. There's a question for you. Do you find born female autistic children also have late developing toileting issues? I know they have picky eating and sleep issues already.
This is for me. Totally anecdotally, I'd say yes. I think, and I do think it's sensory, but this is anecdotally, there's no evidence behind it. Those are just the things I really pay attention to. Patients will get referred to me and, autism hasn't even been on the table, but the minute they're not sleeping very well. Oh, what does that mean? You know, they're waking up at 3 every day. Okay, like, you know, those to me are very, very, they should almost be on the DSM criteria.
Yeah, toileting issues come up a lot.
Yeah, I think it's noise, the toilet, the scary toilet, even though the potty might not be. And I think it's sensory with the diaper. I think there's a lot of like the gut-brain kind of interaction. And I think that kids experience abdominal, like sensory things very differently. And, you know, the minute you get into a cycle of uncomfortable, withholding, it's complicated. Super complicated.
I'd tack onto that too, like anxiety, like TMI from tiny 3-year-old me. But I remember there were times where I would have accidents because I was too anxious to even ask to go to the bathroom, or like too anxious to leave this situation that I was supposed to be in to go take myself to the bathroom. So like that ties into it too, is just like, I know what I need, but I'm not sure how to get it. I'm not sure how to ask for it.
And there's a, you know, the interoception is your ability to feel your insides, right? And so if you don't have it out here, you probably don't have it in here. And I find that if you don't work on developing it on the exterior, you don't develop it on the interior. And part of that is like you do need to bring down the anxiety so that you're actually focusing on your inside, which makes sense because survival-wise, that's what we need to do. Yeah. And I also thought like finding, you know, you were talking about finding some sensory strengths, and that's really important, like being able to show a child that one of their sensory things might be a superpower. And I had this kid who was Inuit, and his sound was off the charts, like, and he could hear somebody, you know, opening a car door outside, and we were really far away from it. I couldn't hear anything. And I said to him, well, if you were out hunting, everybody would revere you because you would hear everything before anybody else did. Mm-hmm. And they would protect your hearing in that way because it's a gift. But because you live in a city, it's more challenging. And he just like looked at me, and I think he knew that I understood him. And I said, so we need to make it more tolerable for you as you live in a city, but for you to know that it's a superpower. And, you know, for lots of the kids, that's the truth. It's a superpower, but sometimes it gets in the way because it's hard for them to function in the environments they're in.
So I have another question here. Do sensory differences change within one's lifetime, or do they fluctuate from one day to another, or do they remain quite consistent?
Fluctuating in all the ways. I mean, part of it is now I'm like more aware of my own sensory needs, but I definitely feel like adult me is way more of a wuss than child me was. Like child me could tolerate children running around me, and now adult me is like, there is more than one child, and they're talking and they're moving, and I'm overwhelmed. Maybe it was because I was used to it as a child because I was in a busy classroom every day. I don't know, but it definitely changes throughout my lifetime. And then day to day, like if I'm having a day where I'm already overwhelmed or stressed out about something else, all my sensory sensitivities are going to be so much worse that day for sure. There's so many different factors that can influence it.
I think that it does change over a lifetime. Unfortunately, you have the most effect when a kid's 0 to 3. And so I used to just work with kids 0 to 3, and I would see them twice or 3 times a week in an early intervention program in New York. And the differences when they were 5 was way different. And then I would see kids that were 5 who had never received treatment. And you have to think about all of that time that is they're living that experience of being in sensory confusion and how traumatizing and anxiety provoking that is. Because they're thinking about something that happened 5 seconds ago because it had an impact on their neurological system, and then you're introducing something else, and to you, you're just going, you know, in a normal course of a day, and for them, they're still thinking about this thing that exploded in their brain 2 minutes ago that was so, you know, every day that you didn't notice it.
I'll add one last comment, and again, I'm not I'm not a sensory expert at all, but I think our tolerance varies day to day. And I think that can be often a response to other things that are going on in life. And so I'm not sure, if like the profile might change, but I think our ability to, be okay with open doors and open cupboards, not okay with that. That can vary depending on everything else that's going on.
Yeah, I've noticed too, adults that I see who say that as they've gotten older, it's been harder for them in some respects to deal with some of the sensory issues. And I wonder if executive functioning has something to do with that. As we age, executive functioning is one of the first things that starts to go, just like vision and hearing. But executive function is one of the first parts of the brain that starts to decline with age. And I wonder if that has something to do with our ability to, tolerate various things like sensory issues. I'm not sure, but it's something I've noticed a lot of the clients, adult clients, complaining about.
Yeah, I mean, they would have, you can have atrophy in the nuclei of your hearing system. And if they are perceiving things as being too much, like if you're in really loud environments for a typical person, then that you also show atrophy in that area, and it also helps you filter out the loud noise. And so they would see quite a bit of a difference. And then because if one of the senses changes, they're all integrated and calibrated to fact check each other. So that would cause you to have perceptual differences. And if you have a really great frontal cortex, you're like, I don't know what's happening, and I usually know what's happening. So that may be part of it.
Yeah, interesting. Like you said, Amanda, it's very complex, isn't it? Like so many different factors. How do you think sensory processing differences might affect family members or peer relationships or just people outside of the person?
I can say from personal experience, it definitely affects relationships. The number of arguments that I've got into with people over how loud the music or some other thing is like, and some people get very offended if you ask them, can you please just turn this down a little bit? So it definitely impacts the people around you. And myself, I will just I'm like, okay, I'll tolerate it. I'll try to tolerate it as long as I can. And that's going to lead to like more stress, more anxiety, and burnout for me. But I'm trying to accommodate these other people / also myself, because I don't want to get in an argument yet again about the same thing that we've definitely argued about before. So it affects people for sure. I think it probably depends on the sensory experience and like what specifically is happening in the situation, but it's not only for the autistic individual. It's like anybody else who is in that environment with them is going to be affected by it too.
I have the same experience with sound and loudness, and I think trying to help the kids understand each other's differences. Oh, he doesn't like that, but he likes this. Because if they're interested in playing with each other, then you can kind of bridge the gap. And so that's what I see in the clinic. And there is this one little boy who was, everyone kept saying he was shy and had social anxiety, but I think it had a sound like that was the focus point, I think, that was creating it. And just giving him a little sign that says, I like when people speak softly, and he would put it up, and that was quite effective. And the other kids were like, oh, and then they would talk more softly, and now he actually interacts with the same kids, whereas he used to run into the corner and hide from them. It's great.
Go ahead.
Yeah, I was gonna say, I think the one thing that came to mind is that it seems like when families have more than one child, who's autistic. One is sensory seeking and the other is sensory avoiding. And that seems to be very, very common. And so families are stuck with like one triggering the other. But
Yeah, like basically on that note, I was going to say like sometimes it can actually create conflict because of different needs. Like I need the lights to be less bright, but somebody next to me might need the lights to be brighter or they can't see. And I'm like, well, I can't see if they're too bright. So like, how do you accommodate that when you both have completely opposite needs? So it's not just about one single person ever, really.
And I think classrooms too, like they're so complex at the moment.
So there's another question here. First, I'll quickly answer the one addressed to me. At what age does a typical person's executive function decline? If I remember correctly from the literature, you peak at age 25 or 26 or something like that. And then it's a steady but subtle decline, like everything else. Right?
Oh, no.
You don't notice
news
it.
to me.
You won't notice it. But I think autistic people might notice it more because they already have some challenges with executive functioning, right? So as everybody's declining in those abilities, for autistic people, it might be more noticeable. But again, I have no data to support this. It's just my sort of clinical hunch. Then I have another question here from someone who has, our daughter is 4 years old and 99% potty trained with rare accidents, but will not use a public washroom at all. Any thoughts on why? We have tried many different things to make her comfortable, but she refuses and cries. This is an issue because she is now in underwear.
Because they're horrible? Short answer?
I see it all the time. I see it all the time in school. Toilets are the same thing. The school's a little bit different because like usually you can have the private bathroom. I've told parents to put a potty in the car. You know, like,
Actually, that's what I did when I was doing potty training with my son. I had a potty in my car.
It's the hand dryers that go off like randomly. Like you walk by them, they go off. The toilet flushing, like they're just scary. They're loud, echoey.
Yeah, and sometimes you don't even really know what the child, unless the child understands themselves what they're afraid of. Sometimes you don't know if it's the dryer or the toilet or the water that splashes up, or there could
Or
be
the
so
fact
many.
that somebody is peeing next to you, very uncomfortable.
Right. There's lots of different things. So you have to figure out what that particular child is fearful of or dislikes.
Yeah. And acknowledging that they're gross.
Yeah, validating.
Yeah.
Yes.
They don't have lids.
Okay, let's see. Any other questions? No other questions yet. Anybody from the audience have a question? Okay, so maybe I'll ask, what do you think the challenges are for us in the field, either practitioners or researchers, moving forward to better understand, sensory processing differences, or what to do about them, or how do we approach them even? What should we be doing in the research area as well as, for practitioners?
I think the evidence-based, people who is living with it and the family members, and get their experiences. Like different people use different strategies, and some things not written in the books, but it's just experience, coming with the families, like different ways of doing it. I think that would be helpful.
So maybe you should write down all the things you did.
Not only like different parents, we do different things. Sometimes like when I talk to another parent, like I get some ideas, So we are doing things that it's not written anywhere. It's just they are day-to-day things that they find out. They're doing things, and then they learn, and and they do again, and so this kind of thing. So I think, get some ideas, like with the people who's with it, living with it, and around the families, and those experiences, I think would be helpful.
I think. So I'm
Yeah, I
sorry.
was gonna say, I think the way I look at it is kind of upstream now, and kind of a time frame. And so the etiology and the work that Tiffany and her team are doing, we need all of that. We need to understand more. I always kind of look at my practice from a future lens, and I know that sounds a little bit strange, but I think in 500 years from now, what would a pediatrician in my shoes be doing? Right? Because obviously not going to be doing what I'm doing now, because 500 years ago, I'd be applying leeches and I don't know, massaging humors, right? And so I know that what we're doing right now is not the correct understanding, not the correct treatment, not the correct anything. And so I try to look at the future. And so that's, I think the work that Tiffany's doing is about this, understanding and kind of blowing things apart. What I would love for that understanding is to not, everybody has their area of expertise, but what if we connected with, anxiety thinking and executive function thinking, so it's not only down one path, because that's already grounded on an understanding that's historical, right? And so I am just about just blow things apart and try to think differently. But then I think that the now part is, what do you do with kids that eat, the outside ring of an apple, half a popsicle, and a little mini go yogurt? That's it. I have nowhere that these kids can get any treatment or support, and that to me is incredibly frustrating, and so I think it's a combination of understanding and then improving function currently.
I want to tell you that all of your comments make me think you are a sensory expert. So you should stop thinking that. Because I think it's a journey that we all, if we use our own experiences, that's what works the best with the children. If a kid keeps going underneath the desk and putting his head down, climb under the desk and see what's going on. And I can tell you it's much quieter on the floor than it is up here. So that's part of why they're doing it. But one of the things that I would like to see researched is low responders, and then how they would fare on a developmental coordination disorder assessment, because I can almost guarantee that they have that, which is also has a sensory component. And so their sensory motor system is just not developing enough for them to actually respond to what you're asking. And within that diagnosis, you actually kind of peak in the middle. So you might do 5 trials really well, and then if you try to do 10 again, you'll go down even lower, which is not what should happen. So if you see that, that probably is part of what's happening. But I would love to see a group of low responders identified, so that some of those, because we can do it using just a questionnaire that will give us our pretty good data, just because it's really easy to do and it lines up with some of the more the BOT and the really more challenging, expensive evaluations.
So a question for Dr. Richardson. I was just wondering, this might be pie in the sky because I know we don't even have enough general practitioners. Is there any discussion of integrated healthcare? Because, I'm a clinical psychologist, right? OT, pediatrician, we all deal with overlapping areas. For that reason, it would make sense to be working together. But I also think there's a lot of good research to suggest, / it was also my experience. I did my residency in Delaware, where there was a behavioral clinic in the hospital, in the children's hospital, and then they also put the psychology residents in the pediatric practices, which were 1 mile away from the hospital, some of them. And there were families we would see at the pediatricians or at the family doctors that we would never have seen in the hospital, right? Because they just won't come to the mental health clinic in the hospital, but they will absolutely go see their doctor, right? And it helps to just be able to walk them down the hall and say, hey, I want to talk to Dr. Kearns about how you're afraid about going in the toilet, right? So it just, in terms of, and I also am particularly bringing it up because of this issue of sensory and anxiety, and when do we accommodate and when do we encourage to push towards the fear, right? So this is my question. Is there any discussion of this? Is there any hope of this?
No, what I, like a passion of mine is behavioral complexity. And I feel very strongly, and I'm not trying to take away, like, people, you know, appreciate their identity as autistic people, and I'm not trying to take away from that. But I feel like we need to move beyond diagnoses, right? I feel like we need to move towards a, like, what are we actually trying to find and to help? And like I work in a clinic called the Self-Injurious Behavior Clinic, and so I see children that engage in severe and profound self-injury, and that's a multidisciplinary clinic, and it is it has been professionally life-changing for me. I would love, and something that's in the back, maybe down the list of my things that I'm trying to work on, is to create a clinic that works and only addresses behavioral complexity, because we have children with medical complexity, like that's a known thing, but for whatever reason, the minute you throw in behavior, that's like it just doesn't even count. And sometimes behaviors are so functionally impairing and limit children and family, like by proxy, you know, their ability to participate anywhere. And I mean, I brought this up the other day, but I think it's like it's invisibilizing. Like, it makes people invisible because it's very hard to leave the house. It's hard to participate in, you know, in activities. It's hard to get on the bus, right? And so that results in a population that's like homebound, right? And so it's a huge interest of mine to like eventually, potentially integrate behavioral complexity within the children with medical complexity. I also find and believe now that the whole mind-body connection, I think we need to start reimagining that, because there is no mind and no body. It's like one thing. And so separating out behavioral complexity from medical, like, makes no sense. And so, like, I'm pushing. But again, from a community, like, I don't work in the hospital, to reinvent or revisualize the way we're actually supporting people, and to have mental health and behaviors be part of what we use in our framing of complexity. So I would love to be part of that.
So there's a comment for Keith. Sarah says doing a DCD questionnaire is a good and easy one to rule out DCD. I don't know if you use
It's a good indicator, and it can also rule it out, and it's relatively easy to do, and it's free. You have to pay for the little DCD cube because it's for kids under 3, I believe. But the other one is free. You can get it on CanChild.
Sorry, not a professional. What is DCD?
Oh,
Developmental coordination disorder.
Thank you.
Yeah, so because Keith was saying that motor development might have something to do with sensory processing.
It has. So the developing your somatosensory system is something that we see in infants, and so the kid who pokes their eye 5 times before realizing they shouldn't poke themselves in the eye is probably a kid who has DCD. The one who does it once and never does it again just probably has normal motor development. But it's a ground up learning experience that we all do. But if your neurological system, for whatever reason, is underdeveloped when you're born, it's a bit harder. And of course, they look like it's an invisible condition, like autism. So everyone's asking you to do things. And when it's on command, it's much harder than when it's either an automatic response to something or given as an option. And so you would see this like in adults with strokes who had dressing apraxia or dyspraxia. And so they would put their like sock on their head or something. But what actually, if you said to them, oh, I'm really cold, I'm going to put on my jacket, they might put on their sweater automatically. But if you, so this one, I was doing this with this one woman, and her sister said, oh, all I have to do is say I'm cold and put my jacket on, and then you'll put your jacket on. But then she knew it was a command, and she couldn't do it. So it's not exactly connected, but to me, there's something connected to it in the mechanism that part of the brain is just not getting enough firing to do it on command. And a command is inherently anxiety provoking over just something that is an automatic response. Yeah.
So getting back, because what you're saying, and then what Dr. Richardson is saying, and Connor's point, if we had all these professionals in a room together, they can tease all these things apart and figure out what parts need to be worked on, what parts need to be accommodated, what parts need to be kind of left alone. But nobody's working together, right? How are we going to change that?
Yeah. I mean, the self-injury clinic is that we lost our psychologist, so, but it is a SLP, a BCBA that's like... Where
is the self-injury clinic?
It's situated at Pacific Autism Family Network.
Oh.
Again, not at the hospital.
Is it a private clinic?
No.
It's part of...
Like, we see the kids together, and so it's a fee-for-service model. But it's a collaborative, you see patients, then you sit around a table and everybody brings up kind of their interpretation of the behaviors and the story. And
is it covered under MSP?
Yeah, like we bill MSP for our time. The families don't pay for anything. But like that type of approach, but again, the allied health are the issue, because allied health, occupational therapy, physiotherapy, SLP, psychology counselors don't have a fee-for-service billing, right?
Right. So that's what I'm asking. How do
we borrowed from psychiatry? So because it's under a psychiatry kind of department head, yeah. But it's incredible. It's one of the few clinics where it's like a complete discussion from your own, biomedical lens or whichever, from, the BCBA, from psychiatry, from medical genetics, from neurology, from, sleep doctor, kind of all looking at the behavior and seeing like what do we think, using our lens, right? What do we think might be driving and maintaining behavior? And then it's like the most collaborative, like I've never been in a clinic like that.
How did that get started? Couldn't we do more of that?
Please. It was an idea identified by Robin Friedlander, who's a neuropsychiatrist at the hospital. And he identified that these kids do need a more collaborative approach. And so he pulled it together. And we have been the same 4 or 5 people since 2017. Like, we have not left. And so I think we have established like a fairly, I feel like I have a fairly good understanding of behavioral complexity in the province.
I actually work in the same building.
At Pathan?
Yep.
Yeah.
I've never seen you.
Any final thoughts? I think we only have 3 minutes left. So yes?
I have a question for Keith. Do you have any example you can share of when you've done a parent sensory profile to help you with your work? Because as a parent, I would like to know what the benefits are for me to use that at home.
Yep.
With my work.
Yeah. So what we did was we had to both parents do them on themselves, And then we had because if you use a sensory processing measure, you can have another person living in the home to be the respondent. And so then kind of cross-matching that, and everyone has to be open to it, and then looking at the child's sensory profile and saying, he has, like, he doesn't like loud noises. I've noticed you actually speak kind of on the loud side. And they, especially for this child, I'm very sound sensitive, so to you sound, I'm sure if you're around a whole group of people who sound like you, that it's fine, but for him, you might need to just talk a little bit more softly. And often the husband is going like this, but it goes back and forth, and hopefully it's a bit playful. And then saying, well, if you're, the reason why you have these complaints about what you'd like to be better for your child is because it affects your sensory profile in that way. And then you use the same thing for the dad. And then they understand that it's not just because that they have a reason, the self-interest in it, and trying to figure out how to make it work, including saying, that's really loud for me if the parents sound sensitive, so that the child knows it's loud for them. So it's not just you saying no because you want to say no, but there's a social reason. And by giving those social reasons for why we need to adapt to each other, it's more likely to actually occur. Like social rules are more meaningful for lifetime learning than just imposed rule. Yeah.
Okay, we have one last burning question from someone who's watching. Carla is asking, can you address the anxiety and neuroception? Neuroception being neural activity with risk assessments. Is anybody aware of that?
From the polyvagal
Yeah.
theory from
Can you repeat
I mean,
the
the only thing I will say is that I think anxiety is underdiagnosed in people with who are neurodivergent. I think that because a lot of our tools, a lot of our screens and checklists are actually based on a neurotypical kind of understanding of what anxiety looks and feels like. I don't know. Oh, well, we will segue to that after. And so I don't actually even use them. I just kind of look at behavior, and I view behavior as an expression of an embodied anxiety, right? This is like me wanting to flee out of here. And so a lot of parents are asking about polyvagal theory. A lot of parents are asking about, neurofeedback. I am still on the fence in terms of its effectiveness, reading articles and such, but I'm not sure. And I'm always cautious about new therapies that are offered as a cure. I'm very, very critical. I'm very sorry. I don't believe anything.
Yeah,
Not even myself.
I like the theory. I don't know about the treatment. I think in some senses, if you're using it and you live in a really remote place, then it's great. But I think it does help us in our understanding of each other, and because the vagal nerve is very powerful, right? And we're talking about hearing and vision, and it's mostly in this little part of your face, which is pretty important to protect, right? So that's kind of how I look at it.
Okay, I think we're out of time, so thank you, panelists. It was very, very informative. And thank you, audience.